In your case, the biographic information that I was able to glean from the internet, after you got your medical degree, you did some traveling to different institutions. Could you maybe tell us a little bit more about that?
Sure. So let's maybe step back. I mean, when I was still a medical student, in Germany you do a thesis to get your doctoral degree, so some research work, either in the lab or clinical. So I did one of those on tumor necrosis factor, and it was not that I thought it was very good, and not sure if it finally made it into a thesis, so I started something else, still as a medical student. And this was then at Peter Lichter's lab, who just came back in 1989 from the United States, where he at least co-developed, if not developed, FISH, fluorescence in situ hybridization. So until then, mostly we did chromosome banding, non-stimulated like today, and the success rate in CLL was very, very low. So FISH, held the potential to study genomic abnormalities not only on chromosomes that you could hardly get in CLL, but in cells, so-called interface
nuclei.
Interface cytogenetics, on the nuclei. So in 1990 or so, I started in his lab to develop and advance FISH, detect the 13q deletion, detect the 11q deletion, detect the 17p deletion, and all that made it finally in the hierarchical model published in the year 2000. So it took quite a while, but our first publications, I think, were in 1992, 1993, with a nice blood cover. Actually, I glued paper photographs on cardboard that you at that time still submitted to the journal via courier. So this was kind of the start as a medical student, and since I liked it so much working on that and the field evolved, more genetics, obviously it took quite some time until the new treatments came along, but at least the biological understanding evolved, and I was happy to be able to contribute, and this is why I went and stayed in that field. Indeed, then finally a medical student, I went to MD Anderson in Texas. Was working also in the lab there in parallel on comparative genomic hybridization, which was a genome-wide test like array-CGH later developed from it. I had my first ASH poster actually at that time, I think 1993 probably, in St. Louis if I'm not mistaken. Very proud, and then went back to Germany and started my residency and further specialization in Heidelberg and so on.
And did I notice that you went to Jerusalem once?
I've been also as a medical student for an elective in Jerusalem, indeed, right, yeah.
Okay, so somehow or another, you really bring back the early history of the CLL lymphocyte couldn't be stimulated initially. I think eventually they figured out a way to stimulate it, but back in those days, it was very low. You couldn't get chromosomes, mitotic figures, and FISH was an ingenious way to go about it. And I think that's incredible that you went from FISH to genomic hybridization. That's really impressive. You also seem to have been involved in the early development of FCR. What do you recall about that? I mean, the addition of let's say the R to the FC.
Right, so in 1996 then, the German CLL study group was kind of formed, founded, or at least introduced their first trial. That was the CLL-1 trial, still a remarkable trial, I think, today for BNA stage A patients. Risk stratification, and the high-risk patients were randomized to watch and wait or early fludarabine treatment, which wasn't beneficial. Watch and wait remained the standard. Fludarabine obviously then was dramatic success. Today outdated obviously as a monotherapy. But building on that trial, there were other trials, CLL4F against FC, and then CLL8, like the pivotal trial licensing enabling trial of rituximab combined with FC, the FCR regimen, which was obviously pioneered at the MD Anderson by Michael Keating and his colleagues as a single-arm trial with remarkable success, but with a single-arm design and not enabling a license. So therefore CLL8 was the trial that indeed in a comparative way reproduced this dramatic efficacy of FCR that Michael had foreseen, with tolerable toxicity profile that finally led to the licensing and a new first-line standard, in fact, in randomized comparison to FC, leading to significant overall survival advantage.
Yeah, I mean, the so-called FCR backbone, or even the FC backbone. I think when fludarabine was first approved as a monotherapy in comparison to chlorambucil, the progressive-free survival was improved, but not overall survival.
Yeah, indeed, that was Kanti Rai's CLGB trial, intergroup trial, testing F against chlorambucil. And initially there was a combo arm, chlorambucil plus fludarabine, that was stopped early due to toxicity.
I forgot that.
But probably that should have been as good as FC, fludarabine cyclophosphamide. Probably dosed a bit too high or whatever. But yeah, that was interesting as well. Also published in the year 2000.
And maybe jumping ahead of FCR, you also are involved in the studies with venetoclax. How do you unfold the history of that?
Right, that also stemmed from my interest and history in genetics. Many of the new, actually all of the new compounds, PI3K inhibitors, BTK inhibitors, BCL2 inhibitors, were tested obviously in patients failing conventional treatment and in subgroups of patients with a 17p deletion who you knew were prone to fail conventional chemoimmunotherapy. So ibrutinib actually was the first one, the PCYC 1117 trial that I was involved in, testing ibrutinib in a single-arm design in CLL, relapsed refractory CLL, with a 17p deletion, and produced outstanding results in this population. Although it was single arm, in historical comparison to FCR in a 17p minus population, even the frontline setting, the data looked so much better and the data was so compelling that it led to licensing. And then similarly, venetoclax, after the Australians, Andrew Roberts, John Seymour and colleagues developed it in the first in human phase 1 design. I had the honor to lead the phase 2 single-arm trial also in relapsed refractory CLL with a 17p deletion venetoclax continuous monotherapy, different than we do it today. But this monotherapy in relapsed refractory 17p minus CLL showed dramatic responses, durable responses, and therefore led to the initial licensing of venetoclax in this patient population.
You know, in doing these interviews, sometimes I try to look for the intellectual high points in terms of the science, quote unquote, but it's also of interest to look at the evolution of treatment. And recently with the memorials to Daniel Katowski, one of his famous landmark papers is that early treatment did not prolong survival. And I think the French had an equivalent finding in their work. And then we move on from that point to where we are now. There was a panel on Saturday evening at Saturday afternoon at John Seymour, that we now have to make a new definition of what signifies success in CLL.
Indeed.
What would you have to say about undetectable MRD?
Right, I mean, the dramatic success of the novel treatments that we have available lead to, such long survival times, and in the case of venetoclax, also so deep responses that we cannot measure residual disease, at least with a classical 10 to the power of -4 cutoff. The majority of patients become undetectable MRD or MRD negative, if you wish to say so. So we need probably more sensitive ways to look into it, not because technology itself is beneficial in itself, but to be more sensitive and to detect these residual bits of disease that may still be present. I think MRD assessment is a very, very valuable tool because it allows for true objective measurement of disease burden or residual disease burden, much better than the classical restaging systems with the CR and PR definitions, and it is more sensitive. On the other hand, we have to be fair and say it is still a research tool. It is very good for clinical trials, but it doesn't have a role in routine practice. I think it is overused in routine practice. Obviously, it is nice if you or I had treatment and became MRD negative. We know that's a good thing, but there's no evidence whatsoever that changing management based on an MRD result is beneficial in the long term. And because this is not proven, you must not use MRD in routine practice to guide management.
Along a similar lines of sensitivity and detection, what role, if any, would this circulating tumor DNA, which I think is starting, I've certainly encountered the term outside of this meeting, the so-called liquid biopsy, which I sometimes think is kind of a peculiar name, but it has come up several times. Would that serve as a more sensitive marker to MRD?
Yeah, I think that's a very nice development. Liquid biopsy is possibly indeed a bit of a misnomer, if you wish. PSA blood testing for prostate cancer is liquid biopsy in a way, isn't it? And we've been doing that for a long time with uncertainty with regard to its use, maybe. So testing for circulating tumor DNA is certainly a very valuable tool, pioneered and arrived in routine practice in lung cancer for detection of resistance mutations towards EGFR inhibitors, isn't it? And or also colorectal cancer with regard to management perspectives. It may sound a bit absurd to use it in blood tumors because the tumor is in the blood already. On the other hand, we see this that at least with regard to the 10 to the power of -4, but possibly even deeper detection limits, assessment of cellular MRD, so remaining CLL cells in the blood or in the bone marrow, comes to its limits. While sometimes you have these patients where clearly there's no detectable residual CLL cell in blood or marrow, but still they have an enlarged spleen or lymph nodes of 2 to 3 centimeters in the retroperitoneum that you obviously cannot biopsy. So there the thinking is that there could be residual disease in the tissue compartment, which you could biopsy from the blood when you try to detect circulating tumor DNA.
One of the posters that I saw that and perhaps the presentation, one of the presentations was how one might be able to use circulating tumor DNA as to monitor for the onset of, say, Richter's transformation. That seemed to make sense to me. But I found myself going to the opposite extreme. The flip side of MRD is MBL, the monoclonal B-cell lymphocytosis. What would it mean if we had circulating tumor DNA evidence of monoclonality, but no B-cell subset, no flow cytometry?
Correlate.
Correlate, yes. How would we figure out where the first lymph node is that supposedly in pure isolation, the first lymph node should have nodal MBL, just an in situ focus, or multifocal. I don't know. How would you envision MBL giving rise to either small lymphocytic lymphoma or CLL?
Right. I mean, as you say, I mean, for Richter's transformation or a disease that is much tissue-based, the whole circulating tumor DNA or liquid biopsy concept holds great promise. We've been together with Kathy Wu showing this, that the genomic abnormalities that you find at diagnosis in the Richter's tissue, when stepping back, you could have found in plasma, or we find in plasma several months before the Richter's diagnosis, in plasma preemptively, so to say, collected. However, prospectively, you don't know what abnormalities you look for. So it's not, it is a test informed by the occurrence of the event, which is limiting the use in practice. Similarly, as you say, that the difficulty is when is the beginning, isn't it? I mean, we know that healthy individuals who never develop lymphoma still can carry IgH BCL2 rearrangement, or the correlate of the 14-18 translocation, a hallmark of follicular lymphoma or other lymphomas. Still, they never develop lymphoma. Or similarly, we know from transgenic mice that the 14-18 correlate is not by itself leading to lymphoma, similar to the 11-14 hallmark of mantle cell lymphoma. So indeed, it is becoming a tricky issue, simply based on some genetic variant, let's say, or abnormality to make a diagnosis, because this is still not the diagnosis, as you say.
Thank you for reminding me about the BCL2 mutation being present in normal individuals. I had forgotten that. Haven't had to remember it for a while. Well, I guess. Do you have any work that involves MBL in the setting of familial CLL?
It's not our focus, but I think this is obviously very interesting, important work. It is connected, isn't it? Germline predisposition to developing such diseases and familial occurrence. There must be some foundations. The question is always what comes before the clonal immunoglobulin rearrangement happens. Is there a mark in the genome or elsewhere that lays a predisposition to the disease?
Yeah, I think these. I always have to make myself a note to remind myself of SNPs, SNP, single nucleotide polymorphisms. I think they're up to 43 or 46 SNPs that are associated with familial CLL, and quite often the findings with familial and Rye stage 0, Binet stage A, they're pretty much similar, even at the level, I think, of driver DNA mutations. I don't think we know for sure just exactly when the immunoglobulin rearrangement occurs. And even a couple of papers which I've recently seen, the detection of the clonotypic cell / genetics can be found as early as 16 years prior to the diagnosis.
Right.
And I think in one case even 22 years. And in one of those cases it happened to be unmutated. So that was a rather long incubation, talk about indolent disease. We don't normally think of unmutated as being quite that indolent. But yeah, I just wonder where, because of my interest in MBL, I always see that as the opposite side of the coin on MRD.
Absolutely.
From a technical standpoint.
Absolutely. I mean, there are many things along those lines, these early detections of the genetic hallmark of a later disease, or as we had discussed, traces that are not necessarily transforming, or now even from the work of the Spanish Elias Campo and colleagues, who traced back at least the clonal abnormalities of Richter's syndrome, of the tumor, years, if not decades, before its diagnosis as a minute subfraction in the CLL clone. So there are things, despite certain genetic hallmarks, that either keep the disease in check, or there are things missing, leading to full-blown manifestation or transformation.
Yeah, that's perhaps even a better example. That's a better example. Well, how are we doing for time, Shay?
20 minutes.
We're at 20 minutes. I'm willing to stop if
Sure,
any other comments that you would care to make about. You probably give lectures or talks from time to time about CLL to medical students and have a historical approach. And I learn from each professor on the things that they emphasize. For instance, when Jennifer gave the presentation, the opening talk, she had a timeline in one of her slides, medical progress essentially in the city of Boston at Harvard. And the first time point was by Minot, M-I-N-O-T, for the discovery of B12. But Minot and Isaacs had a paper prior to that, which was the first paper for the treatment of CLL. And the first treatment for CLL was radiation. And guess what? It worked, but it didn't last long. It reoccurred. I've always remembered that paper as the earliest experimental treatment in CLL.
Sure.
That makes me think I should go back and see in between radiation and steroids if anything else was done. I don't think so, but
Well, I mean, the alkylators that formed, and possibly even the purine analogs with fludarabine, I mean, it's a somewhat similar mechanism to radiation, isn't it? Not delivered systemically, but analogous.
working with the DNA.
No, it's very rewarding. I'm really, truly happy to be involved in CLL. As I said, it's CLL started close to my heart, or to be close to my heart, as a medical student. I like that work, taking the blood of a patient to the lab, fixing the cells, doing fluorescence in situ hybridization, developing all this technology up to the hierarchical model, and then learning about the prognostic implications, learning about therapeutic potential, and obviously all with that came then the novel treatments that we have available. So to me, it's like 30 years since that blood cover, 1993, and it is rewarding to see that on the one hand, FISH remained with a 17p deletion among the mainstays of prognosticators, and on the other hand, that for in particular this very poor subgroup of patients, we have now great treatments available, non-chemotherapeutic treatments that are very much to the benefit of our patients.
You know, you make me think of another question. I'm surprised I didn't ask you sooner about what would be the 5 or 10 most landmark papers in CLL, and the 2 papers that were back to back on the mutational analysis in blood. but certainly the fish study is not only a landmark paper then, but it still is. So would you have any other suggestions for landmark papers in CLL? And you don't have to think about it now, but if you came up with something, I want to try and get a consensus of what people think are landmark papers.
Sure. I mean, CLL8, the FCR, to me still is one, Lancet, because already that illustrated that adding a biological treatment principle, rituximab, a monoclonal antibody, changes overall survival, not only response rate and PFS. So this was the first, before BTK inhibitors and BCL2 inhibitors, prove that biologically targeted therapy is very beneficial, changing the natural history of the disease. Okay, then hallmark papers are sure what we did with Cathy Wu, the genomic landscape of CLL, much beyond what we can determine by FISH, not in routine practice, maybe apart from the P53 mutation. And then the others are sure the BTK inhibitor developments, ibrutinib in the first place, and venetoclax is another targeted therapy of a totally different class. These to me are the up-to-date
hallmarks.
Hallmarks.
I agree with you. Okay.
Thank you very much. Very